Abdominal pain is one of the commonest symptoms in the clinic. Um, it can be because of benign conditions like peptic ulcer disease, or can be because of underlying malignancy. It is different in young people, middle-aged, and elderly people. And so therefore, before going further into the diagnosis, we have to ensure that we get a good history from the patient, especially the duration of the symptoms and any associated findings which will be relevant. And obviously, it depends on the age factor as well. I have a young patient here who's in his late 20s who developed abdominal pain about 6 weeks ago, and the pain was more or less central. It was epigastric, and he had the pointing sign that was positive. And the pointing sign is very important because it means that either there is a problem at the pyloric area of the stomach, or there can be a pathology in the gallbladder, or even pancreatitis for that purpose. Um, Along with that pointing sign, he had intermittent abdominal pain, not associated with vomiting, had some reduced appetite, a bit of constipation, but there wasn't pain radiating anywhere else. He had no history of fever of significance, has weakness, probably because he's had this pain and he's unable to eat much for so many weeks. The investigations which he has had done so far are, as you can see, he's had an abdominal X-ray. He's had an abdominal CT scan with contrast, and also he's had an abdominal ultrasound. The X-ray, if you see, the abdominal X-ray is always taken in a supine position, because in a supine X-ray you will get the maximum information with regards to the abdominal structures, and especially with the gaseous pattern. If you see here, you see that the heart size is normal, and you can also see clear lung fields. There isn't apparently any effusion on either side. The abdomen shows that he's got these gas patterns which are present all the way down. So he's actually got lots and lots of gas in his abdomen, but they're not following a characteristic pattern of either small bowel obstruction or large bowel obstruction. But what this really implies is that he does have what we can call is probably an effect of constipation. A CT abdomen and chest, on the other hand, showed that there was a rim of pleural effusion present on the right side and slight on the left side. This obviously was not evident on the X-ray. So there is an effusion here, but otherwise I do not see any mediastinal lymph nodes, lymphadenopathy. So this pleural effusion, it could be just a reactive pleural effusion, and not because of an underlying pulmonary pathology, but nonetheless, the effusion was there. We're not sure if it was acute effusion or chronic, but this can be relevant to his abdominal pain. Coming down to the abdomen, his liver looks all right, and what you can see is that there quite a lot of gaseous pattern, and the intestines are really full of fecal matter all the way. The kidneys look fine, and there isn't significant lymphadenopathy. So periaortic lymphadenopathy isn't very significant, although you can see occasional lymph nodes here and there, but they're not of any significance. And he does not have any ascites either. So he does not have any ascites, and which means that there isn't any acute inflammatory process perhaps, or chronic inflammatory process going on inside the abdomen. The liver is all right. Don't see any mets or any abscesses in the liver, and the kidneys are fine. And as I said, there isn't significant periaortic lymphadenopathy, although it is said that he does have periaortic lymphadenopathy, and there is no ascites. So the differential diagnosis would be that either he's got peptic ulcer disease because he's got the pointing sign positive, or he may have had an episode of pancreatitis. I have got a serum amylase level here, which is within the normal range, but we know that we can have normal amylase levels with acute pancreatitis. And we know that acute pancreatitis can cause pleural effusion, but likewise can also cause ascites as well, but it can cause pleural effusion. Um, and otherwise, if I would like to perhaps go into some complicated diagnosis, for instance, like inflammatory bowel disease, or tuberculosis of the abdomen, those are the things worth considering. But the history is relatively short. It's less than 6 weeks, which goes against the probability of inflammatory bowel disease of the autoimmune type, although he can have bowel inflammation. I specifically asked whether he had bloody diarrhea. He has not had any bloody diarrhea. He does open his bowels regularly, and he does maintain an appetite. So perhaps the pleural effusion may be irrelevant in his case. It's mild. Perhaps it may be there for a long time, but there isn't much to find on abdominal CT scan or even abdominal examination. And if you look at his face, you can see that he is not pale. Tuberculosis of the abdomen causes severe malnutrition. It's a long history, and the patients are usually emaciated because of malabsorption. And you can see that the face is pink, the ears are pink, so that means he does not have malabsorption. I've checked for his lymph nodes, and the lymph nodes are all intact. The abdomen is fairly soft. It's a scaphoid abdomen. There is no ascites. And as you can see, the patient is saying that this is where the pain is, and that's the pointing sign that is positive. So very likely the pathology is or with constipation in the upper part of the abdomen, and very likely it's going to be the pyloric area. So please do not misdiagnose patients with short history, even if they've got an element of pleural effusion, with complicated diagnosis like tuberculosis. You must have a longer history. You must have a gone complex. Diagnosing tuberculosis without a gone complex can be dangerous. You must have associated lymphadenopathy from the point of entry. So if they've got pulmonary tuberculosis, you must have intestinal lymphadenopathy. If they've got intestinal tuberculosis, they must have aortic lymphadenopathy. So you must have the gone complex. If you do not have the gone complex of significance, do not diagnose a patient with tuberculosis.